All right, I think we're going to go ahead and get started this morning. This is our didactic session, not our unknown session. So we're going to let me know if anybody cannot hear me, let me know. I'm presuming you can hear me according to this. Everything seems to be working. So we're going to talk this morning about diseases that can affect the interface of the dermal junction. And you remember there are two different types of interface dermatitis. There is vacuolar alteration and then lichenoid inflammation. So somebody's chatting, says sounds good. This is great. Okay, good to know. So we're going to hit on things that can affect the DE junction this morning, mostly with vacuolar alteration, or they just kind of obscure it, but it's not really, classically lichenoid. So this first case, you can see shows a superficial perivascular patchy band-like infiltrate of cells. These are lymphocytes here. You can see low magnification that they are dark and black. And whenever we see that, think lymphocytes. Now, obviously, you're going to go to higher magnification. So again, we like to do this at low power first, just to kind of get our mind set in a certain way. But you do want to go to higher magnification, then look at some of the ancillary features that we're going to see. So obviously, superficial perivascular, not superficial and deep, somewhat kind of a band-like infiltrate, but not really obscuring the dermal junction. And it's also got a little bit of epidermal hyperplasia. It's not massive psoriasiform hyperplasia, so it's a slight amount of psoriasiform hyperplasia. And we're going to get a higher magnification. And you can see that there's a little bit of what looks like vacuolar alteration at the dermal junction. Now, this isn't classic vacuolar where there's lots of little holes diffusely at the DE junction, but there's a few areas where there's some little areas of clear little holes at the DE junction. And then I want you to notice that in addition to that band-like infiltrate, that patchy infiltrate in the dermis, there's also some single cells at the DE junction that are lining up at the basal cell layer in these little holes here. So this isn't classic interface vacuolar alteration, although there is some vacuolar alteration, so it's in the differential diagnosis of that. But here we've got individuals, lymphocytes that are lining up here at this basal cell layer with this band-like infiltrate in the dermis beneath, with some dilated blood vessels and some thick collagen bundles. So this is a classic pattern of what we see in early patch stage mycosis fungoides. And it's not a classic vacuolar interface dermatitis, but it's in the differential of that. And that's why we included it for you today. We wanted to show you this really beautiful example of where you see an early lesion of MF. So if you see these features together, band-like infiltrate that's patchy. So you think about a patch, like if somebody's got a pair of blue jeans and they got holes in them, and you put a patch on there, you get maybe a little focal area where there's some inflammation, then the other areas where there's very minimal or limited inflammation. Excuse me, what's that?
Sorry for interrupting. Do not disturb on your phone.
It is on the phone.
Okay.
Yep, it's it.
Sorry.
So anyway, you can see again, the patchy, like a patch here, no involvement. Another area was a little bit more involvement over here. That's what we mean when we say patchy. It's, sort of like putting postage stamps down, and you got places where there's involvement, where there's not involvement. And then you've got these little single cells that are lining up the basal cell layer. That is pretty much classic for early mycosis fungoides. So little holes at the junction, little lymphocytes in those areas, basal cell layer, couple of this, that's MF until proven otherwise. Now, you might say, well, hey, there's no Pityriasis microabscesses. Well, at this stage of the game, you don't see that. You might say, well, gosh, are these lymphocytes really very atypical? At this stage of the game, they don't have to be very atypical either. So we're not using those criteria to make the diagnosis. We're using this pattern. We're looking at the cells lining up the basal cell layer. There may be some slight atypicality of some of these lymphoid cells, but on a scale of 1 to 10, it's probably like a 2 or 3. It's not an 8 or 9 like you see in a nodule or a tumor of MF here. So this is early MF when you're looking at things that look like when you get like a little patchy, early patch stage mycosis fungoides. Okay, here's another condition. And this one really and truly does have a significant amount of interface dermatitis in this case. So this kind of looks a little like MF, but notice that it's got more of a really very nice, well-defined interface dermatitis this time. You really can't draw a nice line between the epidermis and the dermis here. It is obscured, and you can see even at this power, there are holes here. So this is vacuolar, true vacuolar alteration of the dermoepidermal junction. So this is kind of an absolute home run with this topic that we're talking about today, because here you got holes in the dermoepidermal, at the dermoepidermal interface here. This is a classic example of vacuolar alteration. So when you see that, let's say, well, what all do we need to make a diagnosis when we've identified that one reaction pattern here? We're going to look at the cell type. We're going to look at whether there's both just superficial or superficial and deep infiltrate. We'll look at the cornified layer, and here we've got a cornified layer that's got a parakeratotic cornified layer with this broad zone of parakeratosis. Notice that this cornified layer is not in mounds, with no neutrophils at the tips of the summits of the individual mounds. So we don't see that. We just have some serum crust in here. We might have, in some cases, you'll actually get some neutrophils in here, maybe some neutrophils over here. And notice that it's kind of adherent and confluent over a broad front. Those are all important findings as well. If you look in the epidermis, you can see that there's also some diskeratotic keratinocytes in here. So I point a couple of those out. Maybe there's one right there. Maybe that one's dying over here. And then we've got some individually, extravasated erythrocytes. A lot of extravasated erythrocytes. And notice that the inflammation, consisting mostly of lymphocytes, is pretty much just crashing into the base of the epidermis with this vacuolar alteration. So this is classic for Pityriasis lichenoides. And we don't know for sure whether this is an acute lesion of somebody that's had Pityriasis lichenoides for 10 years, or if this is like the earliest lesion that somebody's just getting it for the first time. So we do know that it's pretty classic, though, for Pityriasis lichenoides. So interface dermatitis, vacuolar alteration, extravasated erythrocytes, adherent parakeratosis over a broad front, individually necrotic keratinocytes, and depending upon the degree of involvement, can be superficial or superficial and deep. The classic Mucke-Habermann disease is a superficial and deep wedge-shaped infiltrate. We don't really have that here. Maybe a little bit of that here. There's a little bit of a deeper involvement. But if you really look at classic florid Mucke-Habermann, it's pretty dense, superficial and deep wedge-shaped infiltrate. Here we've got mostly just a superficial perivascular involvement with the interface and the vacuolar alteration, and then the cells kind of crashing into the epidermis. That's pretty classic sort of pattern. You get a lot of epidermotropism in Pityriasis lichenoides also. And that's not mycosis fungoides. You don't see these other changes. You don't see the extravasated erythrocytes. You don't see the parakeratosis like you see here. And again, if you start getting a very dense infiltrate with mycosis fungoides, you will see atypical lymphoid cells, which you generally don't see very much in Pityriasis lichenoides. So this is an acute process here. Could be for somebody that had the disease for a long time, but it's a relatively acute lesion. So let's look at another example. So this looks kind of similar, and this is somebody that had the same disease, but this guy had it for a long time. So this is more of a chronic Pityriasis lichenoides chronica. And notice here we've got the band-like infiltrative cells. We've again got the vacuolar alteration. We've got the extravasated erythrocytes. We've got this adherent parakeratosis over a broad front. Again, if you take somebody that's got Pityriasis lichenoides and you scrape off that, really it's kind of more of a scale crust, if you will. I mean, it will bleed a lot of times, just like it will you peel off the scale and somebody's got psoriasis, so-called Auspitz sign. Same thing can happen in this situation also. So this is a later stage lesion. Notice it kind of got a thinned epidermis, maybe an occasional diskeratotic keratinocyte over here. And again, this band-like infiltrative cells with the vacuolar alteration. So this is a later stage lesion of the same process. Again, Pityriasis lichenoides chronica versus a more acute lesion of Pityriasis lichenoides in the other case. Okay, so let's take a look at this. And this is a small biopsy and maybe small because of the location where it was taken from. It was probably on somebody's face. And we've got a superficial and deep, pretty dense infiltrate of lymphocytes here. So notice we've got a fairly dense lymphocytic infiltrate. And notice where these lymphocytes are located. There's a lot of follicles here, and it's centered around the follicles and also around blood vessels. So this is a perifollicular and also a perivascular infiltrate of lymphocytes. And we're talking today about interface dermatitis, vacuolar. So let's take a look at the interface here and start looking. And once again, we've got some smudging at the dermatodermal junction with some vacuolar alteration here. So let's look over here. You've got some vacuoles at the dermatodermal junction. Here's a hair follicle here. You've got vacuolar alteration in this area as well. We've got follicular plugging. This is a nice example of that here. Follicles are plugged with this parakeratotic cornified material. So I probably don't have to tell you what the diagnosis is here. It's discoid lupus erythematosus. And so DLE will give you, classically gives you interface dermatitis. If you get acute lupus erythematosus, somebody's got the acute butterfly blush phase of LE and you biopsy that, you'll see mostly just vacuolar alteration with really not much thickening of the basement membrane zone, maybe some smudging of the DE junction, but you usually do not see marked thickening of the basement membrane zone because that's a more chronic finding. That happens if the process has been around for a while. And they may not have this density of the infiltrate that we see in the dermis here in this person that's got this chronic discoid LE. And you don't see follicular plugging in acute or even subacute lupus for that matter. So if you look at the biopsy of SCLE and acute LE, they're mostly just vacuolar alteration with a usually relatively sparse infiltrate of lymphocytes. And that can look quite a bit like dermatomyositis, which we're going to look at in a minute. But when you get a denser infiltrate like this with follicular plugging, with thickening of the basement membrane zone, perhaps some residual vacuolar alteration and some smudging like we see here, that's pretty classic for discoid lupus erythematosus, which is an example of what we're looking at in this case here. And notice there are some dyskeratotic keratinocytes here. That's also seen. Anytime you get some interface vacuolar alteration, you can get some dyskeratosis with that also. If it's lupus, you can get a lot of it. If it's Pityriasis lichenoides, you can get a lot of it. If it's something like viral exanthem, vacuolar interface change with some viral exanthems, you may not get very much of it. If you get erythema multiforme, you can get a lot of it, obviously. So kind of depends on the situation that you're dealing with, the number of dyskeratotic keratinocytes that you see. But this is a nice example of a lesion of more chronic discoid lupus erythematosus. Now, let's look at this lesion here in contrast. And notice here, we don't have as much going on. We've got a very sparse perivascular infiltrate here. We've got something going on at the DE junction. And we're going to go to higher magnification. There may be some pallor with some bluish gray material in the dermis, and some of that, most of that solar alteration, but some of that is likely to be a little bit of mucin here. So we're dealing with a connective tissue disease. And notice, look at the dermatodermal junction. Guess what? We've got our good friend here once again, the vacuolar alteration. So when you see this pattern, superficial perivascular infiltrates of lymphocytes, maybe a couple of melanophages here. It's just due to the inflammation that's been going on at the dermatodermal junction with degeneration of melanocytes and melanin dropout going into the papillary dermis. You should think about a connective tissue disease. You should think about maybe acute or subacute lupus. And you should also think about dermatomyositis in the same breath, or a lupus-like or dermatomyositis-like drug eruption. And this happens to be dermatomyositis. You can't tell DM apart from subacute LE or acute LE. They look almost identical under the microscope. So it's really not our job, if you will, to distinguish those two. That really requires a determination with clinical correlation. So you really need to evaluate if you saw a biopsy like this. Does the patient have muscle enzyme abnormalities? Does the patient have muscle weakness? Does the patient have a positive ANA? Does the patient have one of the dermatomyositis antibodies that are associated with that? We now have this MD 5, dermatomyositis can be associated with vasculitis. I don't think that would fit very well with what we're seeing here, but you can just see garden variety features of dermatomyositis in some of these other settings that have some of these antibodies associated with it that are sometimes signs of more serious systemic disease. So you really need to correlate what you see under the microscope with the clinical when you're dealing with connective tissue diseases. So we couldn't just tell you for sure whether this was lupus or dermatomyositis or even a lupus-like drug eruption. So really all we would say here is vacuolar interface dermatitis consistent with one of these connective tissue diseases. But when you see this pattern, you should definitely think of that. So this is a beautiful example of that pattern that we see in these diseases. Again, vacuolar alteration, scattered individual necrotic keratinocytes, and a sparse infiltrate of lymphocytes. So all of those things would go together. And in this case, it happened to be dermatomyositis. There actually, again, was some mucin in the dermis. Not a lot, but some was present in that specimen here. Okay, let's take a look at this one. We've got a superficial perivascular and maybe mid-perivascular infiltrate, lymphocytes here, and we've got some papillary dermal edema, and we've got a little bit of vacuolar alteration here and there. I'd say most of the changes here, though, are probably some papillary dermal edema with maybe a little bit of interface change here as well. And, you know, this is kind of a borderline of what we see sometimes. We get biopsies of things that get sent to us as rule out lupus, rule out drug eruption, something along those lines. In this case, we had pretty good information that this was probably a viral exanthem. Notice the infiltrate is lymphocytic with maybe even a few neutrophils here, possibly even an eosinophil or two. And there's a little bit of vacuolar alteration at the dermatothermal junction as well. So kind of a non-specific pattern, but realize that you can get some interface dermatitis with some vacuolar alteration in certain viral exanthems. I don't know what viral exanthem this actually turned out to be in this case, and in many situations we never find that out. Sometimes the clinician will go back and maybe they'll do today COVID testing and it's positive, and we can say, this is probably related to that. They might do things finding out that something is related to a Coxsackie virus or something along those lines. But a lot of times it's just something like this. It's sort of a relatively non-specific superficial perivascular infiltrate with some mild vacuolar alteration. And in this case, some papillary dermal edema. Again, we really wouldn't know for sure which of the viruses was causing this. Now, there are some viral illnesses, as you know, that give you more specific changes. If you were to get a lot of ballooning degeneration in the epidermis, you might think about a Coxsackie virus like hand, foot, and mouth disease. If you were to see inclusions and large epidermal hyperplasia, you might think about one of the parapox virus infections. If you saw obviously the herpetic viral cytopathic effect, you'd think about herpes virus infection. We don't really see any of those changes here, so we couldn't be much more specific than just to say that this was consistent with a viral exanthem. And once again, you have to have clinical correlation to make a definitive diagnosis. Let's take a look at this. And so here, notice from that first low power, we are dealing with something on volar skin. So again, things that involve palms and soles. If it's an interface dermatitis, one of the things that ought to at least come to your mind, given that we're dealing with vacuolar or interface dermatitis today, would possibly be erythema multiforme. And at low magnification, you can see that there is a mostly lymphocytic infiltrate. You can see that it's hugging the lower part of the epidermis. And as we go to higher magnification, you can see once again that there is vacuolar alteration here at the dermatothermal junction. And notice that there are all these individually necrotic keratinocytes. So this is what we see in an early lesion of erythema multiforme. So this is a really nice example of a fairly early lesion of EM, which is associated again with a lymphocytic infiltrate, mostly lymphocytes, vacuolar alteration, individually necrotic keratinocytes when early, and later the epidermis will become confluent epidermal necrosis. So if you're dealing with a person that's got a later stage lesion of EM, Stevens-Johnson, for example, they will get confluent, full thickness epidermal necrosis. And if you're dealing with someone that's got toxic epidermal necrolysis, for example, they also get full thickness epidermal involvement with relatively limited amounts of inflammation. So they get less inflammation in TEN in most of the cases, not always, but usually, whereas erythema multiforme has more inflammation and kind of goes through these sort of stages of lymphocytic involvement, vacuolar alteration, individual necrotic keratinocytes, then full thickness involvement, whereas TEN kind of wipes out the epidermis right from the beginning without much inflammation. But if you see somebody with EM, you don't really know how bad it's going to get. I mean, somebody that's got something that looks like this could progress to a very widespread TEN-like involvement, even though they have quite a bit of inflammation here and just have a few individual necrotic keratinocytes. So we never get too complacent when we make the diagnosis of erythema multiforme, because, you know, it may just stay as some scattered individual targetoid lesions and maybe a little bit of mucosal involvement and never get very bad. But sometimes we see patients like this that progress to total body sloughing, and it gets pretty serious, even though they have a fair bit of inflammation here. One other kind of pearl that's not seen in this slide, but you can see it in some cases of erythema multiforme. Again, in early lesions, you can sometimes get a fair amount of spongiosis, and it can simulate a spongiotic dermatitis with some interface change. So just remember that sometimes early evolving erythema multiforme can kind of look a little bit weird. So kind of in keeping with the theme of EM, here's another biopsy. Again, notice this one is not from volar skin, and it's got a similar pattern. It's got vacuolar alteration, a lot of necrotic keratinocytes, but notice that this is a little bit later in the evolution of this interface dermatitis. Still some vacuolar alteration here, but you've got this area here where there's really, it's almost kind of like an eschar, where the epidermis was probably confluently necrotic. You've got all these necrotic keratinocytes sitting in what looks like the cornified layer, and that's not parakeratosis. When you see necrotic keratinocytes in the cornified layer, that is not parakeratosis. That's actually sloughing and transepidermal elimination of necrotic epidermis. So really, if you're a purist, it's a form of an eschar. So this epidermis was probably mostly all necrotic. Here's a basket weave cornified layer on top of it. You've probably got newly formed epithelium beneath that. And then now you've got some residual inflammation with some scattered necrotic keratinocytes. So it's probably an ongoing process here. So again, you've got not just these individual necrotic keratinocytes, you've also got this eschar. And then let's look at the interface over here. You can see it's got some nice vacuolar alteration, so there's still some acuteness to this process. You've got an infiltrate consisting of lymphocytes, but you've got these very dense collections of melanophages that are going down fairly deep into the mid-reticular dermis, sometimes even into the upper portion of the lower reticular dermis. And there's one other feature about this condition that is different from classic erythema multiforme, is the presence of eosinophils. So if you see this interface dermatitis with a deeper infiltrate, with deeper melanophages, that's classic for a fixed drug eruption. And in an early fixed drug eruption, you can have a lot of inflammation down here. This is probably a relatively late, but maybe one that's undergoing, it's probably developed, resolved, and it's maybe restarting again. So it's happening at the same site over and over again. And that's why you get these deep melanophages. And because it's drug related, you get the eosinophils. Now, of course, you get a lot of drug eruptions with no eosinophils, but eosinophils are a common finding of a fixed drug eruption. So this is in the family of erythema multiforme, but it's a little bit different because it's a fixed lesion, happens over and over again at the same site, and then you get the eosinophils and these very deep collections of melanophages. So that's a fixed drug eruption, another interface dermatitis. Okay, so let's take a look at one more today. And this is a good example because we're talking about chronology here. Remember, we talked about chronology in the introductory lecture, and we just mentioned it in the erythema multiforme. So once again, we've got a vacuolar interface dermatitis with a relatively limited amount of involvement of the dermis, perivascular lymphocytes. Again, these are going to be jet black dark cells here. So we see lymphocytes only. And notice now we've got this, again, vacuolar alteration with individually necrotic keratinocytes that, as we keep looking at this area, we're involving almost all of the epidermis in some areas. So here we've got confluent epidermal necrosis with a basket weave cornified layer hasn't even had a chance yet to form a parakeratotic cornified layer because the inflammation is acute. And then let's look at the other side of the biopsy, or the two pieces here. And now we've got total confluent epidermal necrosis over a broad front. So this is also in the family of erythema multiforme. This is Stevens-Johnson syndrome, erythema multiforme major. You start off with vacuolar interface dermatitis, and then it kills the entire epidermis, and then you've got this confluent epidermal necrosis over a broad front with an overlying basket weave cornified layer. So anyway, just wanted to show you the same process. And if you look here, it's early, and you can see it's morphing into a more fully developed lesion as we get close to the area. So you can imagine they probably had a target lesion. They biopsied the periphery of the lesion, and over here it was probably just red and kind of urticarial, and in the center was probably dusky, and that's where it had the confluent epidermal necrosis. And again, so it's lymphocytic interface dermatitis with epidermal necrosis. Now, we don't know what caused this example of erythema multiforme major in this case. Could be herpes, could be a drug eruption, could be some other kind of infection, could be a lot of different things. All we can do is just diagnose this as erythema multiforme, and we see this degree of epidermal necrosis. Again, we think of erythema multiforme major. Now, we don't know when we're looking at this, the patient's going to have mucous membrane involvement or not, but most of the time when they get this degree of epidermal necrosis, they usually do have mucosal involvement. So these are the ones where we do get a little concerned. Are we, is this patient possibly going to go ahead and slough large areas of their skin? Are they going to get involved with their eyes and other mucous membrane sites? So again, you want to not be cavalier when you're dealing with erythema multiforme. Okay, so that's a nice example of a lot of good interface dermatitis with vacuolar alteration. We showed you an example of MF, which is sort of a little bit of a differential diagnosis of the pattern, but giving you some other examples of where you get lots of epidermal necrosis, limited epidermal necrosis, minimal involvement with vacuolar alteration, lots of involvement with vacuolar alteration. So this is kind of a spectrum of different things that can give you these patterns, but it is relatively limited number of diseases that can cause this. EM, drug eruptions, connective tissue diseases. Those are the most common things we think about when we see vacuolar alteration. So behooves you to recognize it, master it, ask yourself after you see that what kind of inflammatory cells are there, how much epidermis is necrotic above the vacuolar alteration. Are there other features like mucin, things like that, that may throw you into a connective tissue disease category? And you'll be able to use this relatively uncommon pattern to help you make more specific diagnoses when you correlate these changes with clinical findings. So hope you enjoyed the talk today, and we'll do this again next week. Have a great Labor Day weekend, and we will see you guys next week.